What if I told you there's a brand new prostate cancer test that is 530% more accurate than the PSA test most men have already had? And most patients, and honestly a lot of doctors, have still never heard of it. It's not an MRI, and it's not a biopsy. It's a simple blood draw, the same kind you would get at your annual physical. Today's video is going to change the way you think about prostate screening, because I want to walk you through exactly what this new test is, how it works under the hood, and how the numbers stack up against the PSA test that has been the standard for over 30 years. By the end of this video, you are going to understand why this 530% gap is not a marketing gimmick, why most of the men in your life are walking around with outdated risk information, and what you can start asking your own doctor at your next physical. Before we get into any of that, I want to give you a quick mental model so this whole conversation actually sticks. Imagine you are trying to figure out whether a particular lake has a specific kind of fish in it. The PSA test is basically measuring the overall temperature of the lake water. Higher than average water temperature correlates with that fish being present, but a hot lake does not tell you whether the fish is actually there, or whether it is some completely different fish, or whether the water just got warm because of the weather last weekend. The new test we are talking about today is more like testing the lake water directly for the chemical signature of that specific fish. That is the kind of upgrade we are dealing with here, and that is why the 530% gap is real, when you put it side by side with how PSA performs day after day, in real clinics. Let me put just one quick number on the board before we go further, so the stakes are clear. Prostate cancer is the second most common cancer in men worldwide, with roughly 1 in 8 men receiving a diagnosis during their lifetime. In the United States alone, recent estimates put the annual case count close to 300,000 new diagnoses and more than 35,000 deaths every single year. That means in the time it takes you to watch this video, several men in your city have already been told they have prostate cancer, and a meaningful percentage of those men received that news from a test that gave them the wrong picture to begin with. That is the population we are trying to help with this conversation today. Let me start with the test that almost every man over 50 has heard of at this point, and that is PSA. PSA stands for prostate-specific antigen, and here is the distinction that gets lost in almost every conversation about it. PSA is prostate-specific, not cancer-specific. It is measuring a protein that prostate tissue naturally produces, and that protein level can rise for a dozen completely unrelated reasons. A rising PSA can mean cancer, but when a PSA comes back elevated on its own, the actual statistical likelihood that you have prostate cancer is only about 30 to 40%. It can also mean BPH, which is benign prostate enlargement and has nothing to do with cancer at all. It can mean prostatitis, which is just simple inflammation of the prostate. It can mean a urinary tract infection. It can even mean you went on a long bike ride, had sex the night before, or sat through a really long meeting. All of these things can move the same number on the same lab report in the same direction. That means PSA is very good at telling you what is happening inside the prostate, without telling you what the cause of that thing actually is. In medical terminology, we call this non-specific, and non-specific tests are by definition going to generate a lot of noise. They generate false positives that send healthy men into a cascade of follow-up testing, and they generate false negatives that send men with real cancer home with a clean-looking lab report and a false sense of security. Both of those outcomes are bad, just in different ways. The false positives destroy quality of life and cost real money. The false negatives cost something much worse. Here is a real-life scenario that plays out in clinics all over the country every single week. You go in for a routine checkup, you get a blood test, and your PSA comes back at 6.4. Now 6.4 is meaningfully above the typical cutoff of 4, so right away there is a conversation about what comes next. You get referred for an MRI, sometimes a biopsy. You spend weeks in genuine fear that you might have cancer, and in a large percentage of cases the results come back clear. The elevated PSA was from inflammation, from an enlarged prostate, from a recent infection, or from something as ordinary as sitting on a bicycle seat for 45 minutes the day before the blood draw. The financial and emotional cost of that false alarm is enormous. An MRI without insurance coverage can run into the thousands of dollars. A biopsy is invasive, uncomfortable, and carries its own small but real risks of infection and bleeding. Multiply that by the millions of men who get an elevated PSA every year, and you start to see why so many urologists are frustrated with the current standard. The flip side of this conversation is just as bad, and we do not talk about it nearly enough. Aggressive prostate cancer does not necessarily raise PSA super high at all. There are documented cases of men with perfectly normal PSA numbers who walk into a clinic for something unrelated and walk out with a Gleason 8 or 9 diagnosis. So PSA fails in both directions. It cries wolf too often, and when the cancer is real and dangerous, it sometimes whispers. By now, the message I am trying to get across to you is this. PSA was originally approved to monitor prostate cancer that had already been diagnosed, not to screen the general population. Over time, the medical world started using it for screening anyway, because there was nothing better. But there is something better now. That gap that PSA does not close is exactly where the new test fills in. It is called iso-PSA, and instead of measuring how much of a single protein is in your blood, it measures the structural shape of that protein and the family of isoforms that protein exists in. Now I know that sounds strange, so let me unpack it the way Dr. Sofia explained it to me when I was digging into this for a family member. The PSA protein exists in your blood in many different structural forms, what scientists call isoforms. Some isoforms are perfectly normal and just float around being harmless. Other isoforms are specifically associated with cancer because cancer cells produce proteins that are folded, sliced, or modified differently than normal prostate cells produce them. PSA cannot tell the difference between these isoforms. It is like weighing every apple in a basket and then trying to figure out which apples are rotten based only on how heavy the basket is. The total weight tells you something is going on with the apples, but it does not tell you which ones are bad. iso-PSA looks at each isoform individually and reports out the proportion of cancer-associated isoforms versus benign ones. It is essentially asking, of all the PSA in your blood right now, how much of it carries the structural fingerprint of prostate cancer specifically? That distinction is the entire game. Instead of asking the indirect question PSA asks, which is something happening in the prostate? iso-PSA asks the much more direct question, has prostate cancer actually altered the biology of this tissue, or not? This is why the accuracy number is so dramatically different. Clinical trials, including a major multi-center validation study published in peer-reviewed journals, showed iso-PSA possessing an area under the curve of 0.81 for detecting high-grade prostate cancer, compared to a value around 0.69 for total PSA, even when PSA was combined with free PSA measurements. When you translate those numbers into real clinics, where iso-PSA correctly identifies aggressive cancers that PSA misses and also spares men whose PSA was elevated for harmless reasons, you arrive at that 530% difference in clinical utility that I mentioned at the very top of this video. Let me make sure that point is really clear. We are not talking about a tiny lab tweak. We are talking about a structural shift in how prostate cancer gets identified, and that shift is exactly what makes the 530% figure defensible. Before we get into the exact accuracy and what it would look like for two men with the same PSA number, if this is already starting to change the way you view prostate screening, please consider subscribing. It honestly does help push this information out to the people who need to hear it the most, especially the men in your life who are not going to seek this out on their own. Prostate screening is one of those conversations that men delay for years until something scares them, and that delay is a real part of why outcomes vary so dramatically by zip code, by income, and by family history. The FDA reviewed iso-PSA through its de novo pathway, and the data was strong enough to grant approval as a diagnostic aid. In the pivotal validation study, iso-PSA demonstrated sensitivity of 90.2% for high-grade prostate cancer, which is the kind of cancer that actually kills people. And when paired with the existing PSA result, iso-PSA produced a 55% net decrease in biopsy recommendations across the men studied. That biopsy reduction number alone is huge, and it is paired with no meaningful loss in cancer detection. So the test does not just sound better in a headline, it performs better where it matters most, in the clinic. It is also covered by Medicare, which removes one of the major barriers that keeps new diagnostics out of the hands of the men who need them. Private insurance coverage is expanding quarter by quarter. Here is how iso-PSA actually works in the clinic on the day you show up. It is drawn in the exact same way as any routine PSA. There is no rectal exam required, no fasting, no special preparation. You sit down, the phlebotomist draws a single tube of blood, and that tube is shipped overnight to a specialized lab. The lab runs the isoform analysis, and within roughly 5 to 7 business days your doctor receives a numerical index that places you somewhere on a risk spectrum. Numbers below a certain threshold are considered low risk, numbers above a different threshold are considered high risk, and the dividing line is set so that sensitivity for aggressive cancer stays above 90%, so nothing about the patient experience changes. Only the quality of the information does. So let me show you what this actually looks like with two patients who have the exact same PSA number. Imagine two identical twin brothers, same age, same general health, same baseline. Both go in for a routine PSA blood test, and both come back with the elevated result of 6.4 that we talked about earlier. The first brother follows the standard pathway. He gets referred for an MRI, possibly a biopsy, and spends weeks in genuine anxiety while waiting for those results. He is missing work, he is not sleeping well, his spouse is worried, he is Googling Gleason scores at 2 in the morning. The results eventually come back, and the elevated PSA was from a long bike ride the previous weekend, plus a mild case of prostatitis that resolved on its own. No cancer anywhere. He went through the entire rigmarole for nothing, and the bills are still arriving several months later. The second brother does something different. Right after his elevated PSA result, he asks his doctor, Dr. Sofia in his case, to add ISO-PSA to the workup. That same 6.4 PSA goes through the ISO-PSA analysis, and the result comes back as low risk. The proportion of cancer-associated PSA isoforms in his blood is small. His doctor can look him in the eye and tell him with real confidence that this does not look like cancer. No MRI, no biopsy, no weeks of anxiety, no 2 in the morning internet spirals. He gets to go back to his life that same afternoon. And if the situation were reversed, if the ISO-PSA had come back as high risk, that would give Dr. Sofia a much higher index of suspicion to move forward quickly. She would order the MRI, she would discuss the biopsy, she would not lose weeks to a watch-and-wait strategy when there is strong evidence the cancer is real. The biopsy would happen with a clear purpose, instead of as a fishing expedition. And even if your ISO-PSA does come back on the higher end, that is not a diagnosis by itself either. It is a guided decision, Dr. Sofia would walk you through what an MRI might show, what a targeted biopsy would feel like, and what your treatment landscape would look like if the biopsy confirms what the ISO-PSA suspect. That is a fundamentally different conversation than the one most men are having today, which is, my PSA was a little high, so let us wait and see, and then redraw in 6 months, and then maybe send you to a urologist who is busy, who schedules another PSA, and so on. The new generation of testing compresses that entire delay into a single more informative blood draw. This is the real practical value here. You are not just catching cancer with much higher accuracy, you are actually saving someone from the emotional cost of an unnecessary workup, the financial cost of an MRI that can be expensive if your deductible is not met, and the physical unpleasantness of a biopsy, which is not the most pleasant thing in the world. And I have seen this play out in my own family, because my dad spent decades working alongside urologists before he retired, so I have heard the stories from both sides of the equation. Now if you stuck with me this far into the video, I want to give you one more golden nugget of information that surrounds this newer generation of prostate cancer testing. ISO-PSA is not the only alternative that is starting to gain real traction in the prostate cancer world. There is another test called Stockholm 3 that was developed in Sweden and takes a slightly different approach. Instead of looking at protein structure, Stockholm 3 combines your total PSA level with additional protein biomarkers, a panel of genetic risk variants that look at over 200 single nucleotide polymorphisms across your genome, and clinical factors like your age, your family history, and any prior biopsy results. All of those inputs are folded into a single calculated risk score that tells you and your doctor your actual statistical likelihood of harboring aggressive prostate cancer. It is a multivariable risk model that treats prostate cancer risk as the complex story it really is instead of a single number. A large study out of the Karolinska Institute, published in well-respected peer-reviewed journals, found that the Stockholm 3 test correctly identified aggressive prostate cancer in roughly 90% of cases compared to about 74% with PSA alone. It also reduced unnecessary biopsies by roughly 45% without missing more cancer process. That is not a small improvement, that is a complete change in how the screening decision feels. Stockholm 3 is already being used clinically across Sweden and significant portions of Europe, and it is undergoing validation in the United States right now. So depending on where you live, and depending on what your insurance covers, Stockholm the 3rd may actually be more accessible right now than ISO-PSA. The pivotal STHLM-3 trial enrolled more than 50,000 men between the ages of 50 and 69, and followed them for several years after the initial screening round, which is a population large enough that the results represent a population-level statement about how prostate screening should be done, not a small single-center finding. The reason it performed so well is that it is not asking the simple binary question that PSA asks. It is asking a layered question that incorporates everything we know about an individual patient's risk profile and folds that into a probability. Together, these two tests represent the direction the whole field is moving. Smarter inputs, better risk stratification, fewer unnecessary procedures, and earlier identification of the cancers that actually matter. And they are not the only tests in this new generation. There is also something called the Prostate Health Index, abbreviated PHI, which combines total PSA, free PSA, and a sub-isoform called P2PSA into a single score, and head-to-head studies have shown it to be roughly 3 times more accurate in detecting prostate cancer than the free-to-total PSA ratio on its own. Then there are urine-based tests like SelectMDx and ExoDx that look at RNA signals shed by prostate cells without requiring an invasive procedure at all. SelectMDx has been shown to reduce unnecessary biopsies by roughly 38 to 41% in real-world clinical use, while maintaining very high negative predictive value for high-grade disease. And ExoDx has consistently outperformed PSA on area under the curve comparisons across multiple validation studies. The point is not that any one of these is perfect. The point is that the era of blindly trusting a single PSA number is coming to a close, and a new generation of smarter screening tools is taking its place. Now I want to be completely honest with you about where all of this stands as of filming this video in August of 2026. Neither ISO-PSA nor Stockholm 3 is yet the universal default in the United States healthcare system. ISO-PSA has FDA clearance, which means any licensed doctor in the country can order it, but it is not yet on the front page of every urology practice's standard order set. Stockholm 3 is widely used in Europe and is still working through the validation pipeline in the US. That said, we are gaining ground, more research is being published every quarter, more insurance companies are starting to cover these tests, and the clinical guidelines are slowly catching up to what the data has been showing for years. For now, PSA does remain the primary tool most physicians are working with, because it is what every insurer pays for without question, and because it is what every electronic medical record is set up to order by default. But honestly, if you have an elevated PSA level in your chart right now, and if you meet the criteria for these newer tests, you may want to bring one of them up with your own doctor and see whether paying out of pocket makes sense for your situation. The cost is not trivial, but it is dramatically less than the cost of an unnecessary MRI plus biopsy plus weeks of lost sleep, and the cost only goes down as adoption goes up, which is happening right now as we speak. If your doctor is not familiar with ISO-PSA yet, you can bring the clinical literature yourself. The validation study is open access, the FDA approval letter is public, and most physicians will welcome a patient who shows up informed and engaged. Dr. Sofia told me personally that the patients who come in with a printout and a polite question are the patients whose care changes the fastest. Now for the broader question of general prostate health, even outside of cancer screening, there are a few things every man should know. Saw Palmetto has meaningful peer-reviewed evidence to support healthy prostate function and may help address the benign enlargement that frequently elevates PSA levels in the first place. I have the best and most affordable option for Saw Palmetto on Amazon linked in the description below, so you can check that out if you want to support your prostate on a day-to-day basis. There are also lifestyle factors worth paying attention to. Lycopene from cooked tomatoes supports prostate cell health with consistent evidence over the past 2 decades. Regular physical activity is associated with lower PSA levels across population studies. Reducing prolonged sitting, especially long bike rides right before a PSA draw, can prevent the kind of mechanical PSA elevation that gets men sent for unnecessary biopsies in the first place. Maintaining a healthy weight, limiting alcohol, and eating a diet rich in cruciferous vegetables like broccoli and cauliflower all contribute to a prostate environment that is less likely to develop problems in the first place. And if you have a first-degree relative who had prostate cancer, your own screening conversation should be starting 10 years earlier than the general guideline, because family history is one of the strongest predictors of risk we know about today. None of this replaces the new generation of testing we have been talking about today, but it does set the foundation that makes any test result easier to interpret. Father, I thank you for this man right here. You knit me together in my mother's womb. I praise you because I am fearfully and wonderfully made. This comes from the book of Psalm 139 verses 13 and 14. Your body is not an accident. The fact that there are smarter tests being developed right now to catch this disease earlier is not an accident either. In my next video, I am going to talk about the single thing that can activate your own body to eat its own diseased cells, including cancer cells, so you can prevent cancer without it ever forming in you in the first place. If you are interested in what that process is and how to activate it, you are going to want to check out the next video right here.